this. We call it clinical uncertainty. It's complexity. The full list, a colleague and I some years ago did a formal evaluation. We came up with more than 70 items, 70 reasons that clinicians might vary. This was a top 4 though, and it's the same items that some other investigators had also identified along the way. We used an empiric method, they used opinion, came to the same conclusions in this particular instance. I'm going to run through them very quickly. Item number 1, it turns out that we have evidence for best practice. When you're building an evidence-based best practice guideline, you have actual evidence only about 15 to 25% of the time on average. When I say evidence, I love it when I get good level 1 evidence, randomized controlled trials. I'm quite pleased when I get good level 2 evidence. That's strong observational designs, quasi-experiments, case control studies, case series. I'll even accept level 3 evidence, expert consensus opinion using formal methods. But at a level 3 evidentiary standard, on average, we have evidence for best practice about 15 to 25% of the time. Anybody who's tried to build an evidence-based best practice guideline has experienced this. Now, of course, it's not uniform. You get in some areas like pediatric oncology, by the structure of how we deliver care, it's much higher, close to 50%. On the other hand, general pediatrics, really close to 0. General surgery, where I first trained, really close to 0. You see the problem? It means that physicians and nurses can hold legitimate differences of opinion about what's best. For 85, 95% of what we do, you can hold legitimate differences of opinion about what's best, and we do, and it produces variation. The second problem is a funny flip on that. Not only do we lack evidence for most of the decisions we have to make, at the same time, new evidence outstrips our ability to deal with it. It has to do with the rate of increase of new medical knowledge. Best estimate, medical knowledge is doubling. It's exponential growth. Its doubling time is about 3 to 8 years. And the rate of increase has been increasing. Well, 3 to 8 years. That means that a new internist coming into practice today, a new family medicine physician, is going to have to learn, then unlearn, and relearn half of their basic medical knowledge base a minimum of 6 times across the course of their professional life. How do you do that when your days are full of patient care? Well, the evidence shows that we don't. It shows that when physicians enter practice fairly quickly, they start to show, quote, large declines in general medical knowledge. It's not that we forget things, you just can't keep up. Even with all the specialized tools that are available to help us do that, you still can't keep up. And that's fairly well documented, just in passing. Now, interestingly, the new knowledge we're getting is not the right knowledge for problem number 1. I really need comparative outcome studies to say what's best in this circumstance for this patient. What I get are nearly always new drugs and new technologies, just making the mix a little bit worse, you see, as opposed to answering the core questions I have to answer in order to deal with variation in care. Item number 3, again, is the work of David Eddy. He started to carefully examine the antecedents, the roots of expert opinion. Short version, guys, it will completely destroy any faith you may have ever had in expert consensus opinion as a basis for best practice. He showed that on any particular topic, when you ask the experts in highly structured ways, you get basically full range from 0% rate up to 100% rate or close to it, all right, with no discernible pattern of response. He showed that across every specialty group. What's happening behind it, we're relying upon subjective recall. We're trying to assess experience in our heads. Now, if you're pattern matching as a physician, we're kind of magical. If you're pattern matching, we don't know how to match what happens in the expert mind analytically in a pattern matching setting. The trouble is more and more of what we do in medicine is not pattern matching, it's rate estimation. It's probabilistic. And that same body of literature shows that if I ask you to estimate a rate, you will be dominated by 2 or 3 recent cases, or if you had a particularly impressive case in your distant past, good or bad, that will dominate your thinking. It also shows that we tend to dramatically misestimate the rates. We tend to be very, very generous to ourselves, by the way. Typically about a 20 to 50% misestimate rate. and it tends to be that on average we see it as much more positive than reality would support, just in passing. Again, what it does is destroy any faith you may have ever had in expert consensus opinion. The underlying argument is that as the profession transitioned across those 100 years, when we started it was mostly pattern matching, but today it's mostly rate estimation. You know, I just went through a case not long ago. I was consulting on a breast cancer case. A 54-year-old woman, unfortunately, she had stage 3 disease. We went through 4 major decision nodes relative to her treatment. At each decision node, we had between 2 and 4 treatment options. And I was keeping track of the questions she asked me. Well, Dr. James, if I choose this, what's the chance that I'll die? That's a rate question. It's not a pattern matching question, it's a rate question. Well, all these complications you've told me about, what's the chance that that'll happen to me? That's a rate question. Almost every question she asked me was a rate question. And what the underlying literature shows is when you're dealing with rate questions, the expert human mind does very poorly indeed in making those choices. Now, this applies directly to choices about treatment when you're talking about appropriate use criteria. It fits directly in that category, you see. Finally, it's just core complexity. In some studies, we were able to show significant variation, same physician, same patient, morning to night rounds. In fact, it was with ventilator management. The first time we showed up ventilator management for patients in the ICU with well-defined conditions. The underlying cause of this variation within an individual physician turned out to be just pure complexity. There's a literature. The root article was published in 1956. It's on the slide, Miller, and his title said it all. He was investigating how many factors the expert mind can consider when making a clinical choice. And the maximum number appears to be about 9. It turns out that in most clinical circumstances, you need to consider more than 9 things. You see? What we showed with ventilator settings, there were about 40 critical things that you probably should consider with all the elements of setting a ventilator. In fact, if we just went backwards and assumed that every time our expert academic intensivists were seeing the patient, they were subconsciously and by their own evaluation at random, when we looked at it looking backwards, at random, selecting 6 or 7 or 8 factors to optimize. And when we did that, we could completely explain their ventilator settings. We could work it backwards. The trouble is there's about 40 factors, and 40 is more than 9. And on that foundation, we're able to show significant variation, same physician, same patient, morning to night rounds, in that kind of a controlled environment. See the idea? Now, yeah, here I have craft a medicine approach to practice, every physician a standalone expert coming up against, on the other side, this clinical complexity, the emerging reality of modern practice. The next thing you need to know